When we speak about cancer, sir, you would know the ones that affect the women typically would be breast, ovarian, cervical. There are multiple cancers, right? And the statistics around these cancers are fairly alarming. We, as GE, we wanted to draw more attention towards breast cancer and generally towards cancer which affect women. But let me take a minute to talk about our guest today, our expert today. Dr. Harit Chaturvedi is a renowned onco-surgeon in India with an experience of over 30 years. He has worked with some of the finest hospitals in India, and presently Dr. Chaturvedi is the chairperson of Max Institute of Cancer Care. Dr. Chaturvedi is widely appreciated for his clinical and surgical skills in oncology. He supports cancer awareness and has been a crusader against tobacco usage through various cancer foundations. Once again, sir, thank you for taking your time out to speak to us. It's a privilege to have you with us. As I was saying, Dr. Harit, what are the most common types of cancer for women? And are there any cancers where you see there are alarming trends where more focus is needed from our side, from clinician side?
Actually, the trends in cancer have been evolving or changing over time across different diseases. For example, so as far as the patterns of incidence is concerned, we have seen huge trend changes in the trends in women's cancers. And for example, breast cancer used to be number 2 and cervical cancer was number 1 in India. And today, breast cancer has taken over cervical cancer. As you have mentioned about the global trends, that there's increasing trend of breast cancer. And the pace of increase is almost 1.5 to 2% per year. That is the pace at which the incidence is growing as far as breast cancer is concerned. At the same time, in the cervical cancer area, it's going downwards. So that is a plus because there's some effect of vaccination, more so of less children, better hygiene, better antenatal, perinatal care. So therefore, less risk of HPV infections, and therefore cervical cancer is going down. However, the trends is because of the lifestyle things. The breast cancer is on the rise. And for that, multiple reasons are there, including the dietary patterns, the increased BMI, the delayed pregnancies, or nulliparity. More and more women forced in the workplace, higher the incidence. Having said that, these are certain things which can be balanced with better awareness. So one can take care of the health by fitness, and one can take care of the timing of pregnancy or breastfeeding and things like that. As support will increase for women for taking care of these essential biological needs also, probably there'll be a better understanding and application. But as far as trends are concerned, breast cancer is certainly on the rise and something we all need to address.
Yeah, and that's true, and that's clearly what the data has been indicating. The incidence has been rising. So, if Dr. Harit, if we were to think about gaps, what can we do, right? What should a patient do? Where do you see? So I was just saying, where do you see would be areas where a women should focus about? And you mentioned a few of them, whether it's about health, BMI, nutrition, awareness about health checks. Are there more areas that they should look at, and more from a institution standpoint, society standpoint, or clinician standpoint? Are there gaps in understanding that we should also be looking at plugging and working towards?
So I think this is the most relevant question. This is the area where we all need to work together. Now, when you were introducing, you said that unfortunately the data, the unfortunate part is that most of our patients still present in advanced stages.
Yeah.
So if I talk about gaps in the whole journey, from prevention to early detection to treatment options to going in for adjuvant treatment and therapies and then support and care and rehab, across there are gaps where somewhere society has to play a role, somewhere the patients have to play a role and the caregivers have to play a role. The clinicians have to play a role, not just the oncologists, the whole clinical community, the GPs, the gynecologists, everybody needs to step in and understand more about breast cancer so that each patient gets the right benefit. And likewise, the teamwork within the oncology teams is also very critical. Now, if I start from prevention, so as we discussed, or as I mentioned in the previous question, that taking care of your fitness, BMI, whenever pregnancy happens, or taking care of the breastfeeding and taking care of the child. So these are certain norms that they're shifting trends across the society, which is fine, which is important, because women empowerment and job is equally important. At the same time, how the society can plug into these biological factors to ensure that support is there for the women, for our own sisters, and my own daughter is there in workplace. So like that, I'm saying that everybody needs to understand these things and apply that in practice. Now, as far as the early detection is concerned, we all know that breast self-awareness is critical to pick up early breast cancer. We also know there's a role of diagnostic tools like use of mammogram, ultrasound, use of biopsy at the right time, all these things, plus the application or the awareness at the clinical level by the GPs and gynecologists. If I look at this whole piece of early detection and diagnosis making, even if I want to say that screening is not something which I will very much pitch as far as India is concerned, but I'll definitely say that we can all collectively make a big difference in early detection. First thing, what happens the moment there's a lump, there are very limited centers or facilities for full evaluation. And more often than not, even the doctors have a tendency to, if it's a mobile lump, it's a fibroadenoma. The issue is that all lumps initially are mobile, even cancerous lumps are mobile. So no symptom in breast should be passed without what is called triple test: clinical evaluation, radiological evaluation, and taking a sample or true cut biopsy. Now today, though mammogram access is limited or may not be that much in tier 1, tier 2 cities or in the outside the metros, but ultrasound and biopsy is certainly available at most of the centers.
Yes.
So if the awareness grows, probably we can plug that by ensuring that every woman, whether she's 22, 3, 24, or she's 45, every woman, if she presents with a breast lump, she must have a mammogram. If mammogram is not available, she should have an ultrasound of the breast. And once ultrasound is done, a biopsy should be done for every lesion which is targetable. So if we ensure that across our country, I'm sure that we'll pick up many more lesions in early stages compared to stage 3 and 4. And that itself will be a big shift in and improve the outcomes. So this is a gap which we can all fill together. There is something, the facilities are there, there's a knowledge gap, there's an understanding gap, and there's an application gap, which we can fill. Now, if I go on to the treatment part. So typically when I am dealing with patients, I talk to them, there are 3 different steps: diagnosis, staging, and then we go on to make a plan. Now, today, as we know that based on a lot of recommendation guidelines for treatment, a treatment is not started till you know the tumor type, what is the ER, PR, HER2 status. Treatment is not started without having a proper evaluation of the axilla, whether the ultrasound has been done or not done. Treatment is not started without a proper staging workup. So unless a proper diagnosis, proper staging is there, no rushing into treatment. Unfortunately, off and on we see patients having surgery or ad hoc treatment has been done because without completing these steps. So if we all systematize that and make a process which is the common language in the public domain, that we have to complete this step, we have to complete the next step, and then we go on for treatment decision, probably will make much better decisions. Also, so this is another area where we can plug in that the understanding of tumor type, understanding of proper staging, axillary evaluation is critical to get the best outcomes in terms of treatment. Now, as far as surgical options are concerned, there is another thing which I will say is something which, as a surgeon, I feel that I am responsible to talk to my people, gynecologists, general practitioners, and communicate repeatedly. See, it is not their domain, it's our domain. So responsibility is on us, not on them. That whenever we take a decision, whether we can do a conservation surgery, whether we can do a mastectomy or oncoplasty, so that conversation often gets diluted because somebody back end conveys that probably mastectomy is the safest procedure, which is not true. Which is not true. The truth is that breast conservation is safer, or even better, if I can say, than mastectomy, because that restores the whole body image and still cures cancer as much as a mastectomy will do. So why not? So So there we all need to understand that what kind of imaging has been done, what kind of treatment has been, evaluation has been done. And then if the person is suitable, today conservation must be offered. Sentinel node must be offered. So we have to ensure that this thing happens in a proper manner. And this can only be possible if we close the gap in terms of understanding of how these decisions are taken at all levels. So on our side, I try my best to convey to the patient and wherever possible get the opportunity to talk to doctors. But I think a lot more can be done if the industry also partners and all of us continuously keep working on it. This will make a big difference. And then once the treatment is happening, then obviously it is the ownership of the or responsibility of the clinical team to work in tandem.
Yeah.
The thing is that cancer treatment is not done by a surgeon or a medical oncologist, radiation oncologist, or pathologist or radiologist. It is done in continuity. And there the seamlessness, the connectivity of the team is critical to ensure the best treatment is delivered to the patient.
So I think you've touched lot of important points. How we need to create more knowledge and awareness amongst the patient, how we need to create more harmonization of treatment, of diagnostics and treatment amongst the fraternity, and integration. I think a very important point you touched upon is how do we integrate and share seamless information across the board within the fraternity who's taking the clinical decision, right? I mean, that continues to be a biggest challenge the way we see it as well. And use of tumor board is something that very few institutes do it successfully. I mean, a lot are talking about it, but how to use it successfully and integrate it with the care is what remains a challenge. So
I also believe that tumor boards are the best platforms for even the team to work as a team and learn together.
Yeah.
So anybody raises a question, everybody's trying to answer that question and finding new knowledge. That actually keeps you moving forward. So tumor board is very important for patient care. Tumor board is very important for professional growth also. So for both the things, it is very critical. So it is very helpful. Yeah.
Absolutely. And one is a format, the tumor board, and the other is also use of technology. The way we are seeing, and I'm not just talking about breast cancer, I'm just probably, I mean, if I were to take a step back, talk about cancer which affect women in general, we are seeing new and new innovations, technology being introduced in diagnosis, in treatment. What are the trends that you are seeing? Are there specific technologies which you are seeing are upcoming, are very relevant for detection and treatment of cancers related to women?
So, Shishir, as we talk about women, largely it's about breast and the ovarian and uterine and cervical cancers. So I would say there's been a dramatic shift in terms of use of technology in every way. Now, for example, technology today, we can select, if we talk about diagnosis making first, as I was mentioning earlier, we think of only mammogram for breast cancer. Today, I would say if mammogram is not available, please do ultrasound. I have as much confidence that at least a decent evaluation is possible. Today, everybody has a guided biopsy.
Yes.
So these technologies are making a difference. Today, we are aware of a lot of research going on in that space in terms of thermal scans and this and that. What will really come out in time, we don't know at present, but certainly there's a lot of space work happening there. Likewise, the usage of a universal tumor marker, at least half a dozen studies are going on where people are looking for one simple blood test, which will help us identify the person, whether you are in a high risk category or probability of getting cancer is high or low. So if you're able to do one of these things and succeeds, probably we will really gain in a very big way, because then you are able to screen your large population by simpler tests and execution becomes much more possible. Now, as far as the cervical cancer is concerned, pap smear or taking a cytology, doing a cytology is a gold standard today, cytology. And that itself is improving the detection and the risk evaluation and therefore strategies to reduce that. Now, not just in terms of detection, but also in terms of treatment, technology has played a lot of important role today. Sentinel node biopsy has become a gold standard for breast cancer, in node negative breast cancer. Sentinel node biopsy is relevant for endometrial cancer. Okay, all laparoscopic hysterectomies and robotic hysterectomies, we are able to, in a selected patient, good grade, T1 disease, you are able to do a sentinel node and sample that node. So we don't have to go through a whole gamut of extended dissection and then find all nodes free of disease. The woman has not benefited. At the same time, you have the morbidity of a full dissection. So that is also possible because of the technology, the use of technology. Likewise, in ovarian cancer, the use of HIPEC itself is because of the technology, which has benefited a properly selected group of patients in terms of survival. So use of, after you've done a complete cytoreductive surgery, what we do is we put in chemotherapy at a temperature of 42 degrees for about 90 odd minutes in the abdomen. That helps in addressing the peritoneal surface cells and helps in improving survival in that subset of patients. So technology is, I think, today technology is synonymous with advanced treatment because we are all riding on that, these tools and this knowledge. And I would say even the use of AI, though I cannot directly say where it is going to make a difference, but use of AI and analysis of data helps in identifying how you're doing, how you can improve yourself, how you can collectively do better treatments. So that is all possible because of technology. And new research is also happening because of better data collection and analysis and things like that.
India still sees a big divide, right? In metros, the most advanced technology is available. Centers of excellence like yours and few others will have the best technology available. But a lot of women will not get access or to information, to expertise, to technology. What would be your suggestion to them and to clinicians who do not have access to the most advanced technology in the first place? Like they may be late adopters, if I were to call it that. What would be your message to them? How should they think? Because, as you said, ultrasound can still play a role which may not replace mammogram, but play a sufficient enough role to detect. What message would you like to share with them?
So I would say that first and foremost, I want to say that responsibility is on me and people like me, my tribe, the oncology community, to actually make it happen. The tools available, I will discuss about them. So today, the most important tool which is underutilized is the digital connect.
That's true.
That is most fortunately, during COVID, we have grown 10 times in that space. But I think we need to grow 1,000 times, not 10 times, 1,000 times. If we use this power alone, Shishir, I must say that I believe that even our remote areas will get hugely connected. And a lot of work is happening in that area. At Max, or for example, any institution, and I feel that even Max should own that. If we all take up small areas and take that, define an area there where we spend so much effort and time in terms of education, in terms of connectivity, in terms of just making sure that all the doctors in that area, all the patients in that area, everybody who is 10th pass will get this information or whatever, some criteria to make sure that every person is ticked and you are connecting with that. I'm telling you, this will not take too much time. And I'm very optimistic that in the next 5-7 years, Indian healthcare will transform. It will actually give solutions to the world because if you want to use the word jugaad, I'm fine. But in terms of innovation, I think Indian mind works very well. And we are challenged by the huge burden of cancer. At the same time, we have an opportunity because players like GE and Roche and all of the players, they are all investing into the society. And therefore, together, we can make a big difference. So in terms of education, in terms of early detection, in terms of education for primary care physicians, for primary care physicians or secondary doctors, if we create engagement models, probably a lot is possible. The only problem is there's lack of trust. And therefore, people don't engage. They feel that what is it for me? What are they doing for? There will be something which I'm missing out. So I think we have to get over that cynicism, that just enjoy and do what is there in front of you. Probably you'll get to more to do and more to achieve in that. We have seen a lot of diagnostic centers in private space.
Yes.
But there are no diagnostic centers by the government. There is no entity called diagnostic centers by the government. Now, government either has mohalla clinics as in Delhi model, or they've got a secondary and tertiary hospitals, which are very people intensive, management intensive, cost intensive, and therefore they have their own dynamics, which just needs a lot of support to just manage it. If we create something in between these two as diagnostic centers, which has the facilities not just in ultrasound and CT and guided biopsies, but I'm saying in terms of endoscopies and biopsies.
Yeah.
My belief is that this intervention, that every district hospital will have 5 to 7 diagnostic centers attached, which will extend somewhere 15-20 kilometers outside, or whatever network, whatever numbers work around that. And that report flows to the district center. These centers are open from 8 a.m. to 6 p.m. and the work is happening. I believe that a lot of cancer detection will happen early, a lot of transformation is possible. And this will be a game changer in terms of fighting cancer in India.
Absolutely, sir. And I think, like the way you mentioned, today, one of the challenges a patient faces is to travel very long distances, especially for oncology, for cancer care. And if the infrastructure develops in the manner that you suggested, if we are able to integrate them with technology, that challenge can be taken care of to a great extent, making it convenient, seamless, and effective for the patient, for the clinician as well. So with that, I would like to thank you, Dr. Harit, for your time. It's been a very informative and engaging conversation. And we look forward to seeing you spearhead more and more initiatives and set the direction for the community for cancer care in India. Thank you so much for your time.
Shishir, thank you. Thank you.